Thank you everyone for joining us today. We're going to get started right at 1 o'clock.
Welcome, everyone. I'm Katina Cummings, and on behalf of the Northern Vermont Area Health Education Center and our partner organizations, welcome to session 4 of our 5-part series, Quality Care is Equitable Care, the case for culturally and linguistically responsive care. Persistent and stark health disparities between white and minority populations have challenged us all, especially over the course of the pandemic, to confront and help solve discrimination in healthcare and beyond. Ignoring racial and ethnic health disparities is costly for underserved patients, providers, and society. And we're learning that culturally and linguistically responsive best practices are necessary tools to achieve a more equitable healthcare system. We have learned that health equity is both a principle rooted in social justice and fairness, as well as a destination, and the reasons quality care cannot be achieved without equity as a key lens. We also learned that health disparities by race and ethnicity in rural areas are present and widening. And in the last session, we learned that implicit or unconscious bias is a root cause of racial and ethnic inequality in healthcare. But together we can mitigate and eradicate it to achieve debiased care and a more equitable healthcare system. In this session today, we will introduce you to 2 essential clinical competencies, often that are overlooked by clinicians and others, to ensure a responsive clinical encounter. Tools to explore the patient's culturally determined beliefs around health and illness, and strategies to work effectively with qualified medical interpreters. You should have received an agenda earlier in your email today. We will have 2 presentations by our key presenters, followed by a Q&A and an interactive opportunity with our full panel. You also should have seen our announcements. This webinar is being recorded. Links to the continuing education forms will be emailed to you after the program. Please, we encourage you strongly. It helps us to complete the evaluation at the conclusion of the webinar. And with respect to your Zoom controls, you know they're at the bottom of your screen. Please use the Q&A button for questions directed to presenters and the conference organizers. So before I introduce our 2 guest speakers or guest presenters, I would like to share a few slides and concepts to lay the groundwork for our learnings today. When a clinician interacts with a patient, 3 cultures meet, at least 3, by the way: the patients, the clinicians or other professional caregiver, and the culture of biomedicine, as expressed in clinics, hospitals, and med school. All 3 cultures meet in different ways and influence the actual encounter and outcomes of that encounter. So to understand and serve diverse patients, providers must recognize their own personal and cultural biases, based in part on our life experiences, that influence the ways we think about healthcare, our patients, and making clinical decisions. I love this slide. Some of you have seen the research on culture, and this is the cultural iceberg concept. Culture is like an iceberg. There are visible and invisible behaviors. The what and the why. The what is above the frozen water, and the why is below. You could look at the what as visible behaviors and the why as invisible. And the invisible lies in the deep structure of the iceberg. You can see some of the differences between what is visible and what isn't. What is conscious and taught, that is visible above the line, above, that is visible to all of us, and below, attitudes and beliefs that are intangible or implicit, such as implicit bias or caught. So the key here is that culture is not static and it is not homogeneous. And like an actual iceberg, some of the invisible factors of culture can move to the visible. And conversely, certain conscious behaviors, for example, can become implicit. In the next slide, we understand that many researchers and practitioners have recognized a continuum of cultural effectiveness, from cultural awareness to cultural humility. So we consider cultural awareness, consider that at the first level of the continuum, recognizing and understanding that we all have different values shaped by diverse cultural backgrounds. And we're sensitive, perhaps, hopefully, to the need to ensure quality communication with members of another cultural group. And at the highest level of this continuum is the embracing of cultural humility, which is an interactive approach or stance toward understanding culture and our patients. It invites us, this approach, to be committed to best practices, not just awareness. It requires a commitment to lifelong learning, as well as continuous self-assessment, reflecting on our own practices and prejudices, sometimes including biases. It allows us to be uncomfortable or have comfort, I should say, with not knowing, and that this discomfort, if it's produced, is all right. And key to understanding cultural humility is building trust and understanding to help empower families and optimize patient care. We also must recognize that cultural humility is the recognition that there does exist a power and privilege imbalance between clients and health professionals. So in order to practice cultural humility, we have one key goal. We strive to understand rather to inform. We approach another person with openness and learning and respect. We ask questions rather than make assumptions. And you'll hear today how key all of these components are to cultural humility. And we embrace and learn about similarities and differences between clients and health professionals. This approach can help providers understand clients' health concerns, experiences, and preferences for care. So now I'm pleased to introduce two of our key presenters today, Dr. Heather Link and Linda Lee. Dr. Link, who will speak first, is a pediatrician at the New American Clinic, Pediatric Primary Care at the University of Vermont Medical Center, where she's been providing care for refugee and immigrant patients for the last 6 years. Dr. Link works to facilitate the relationship between family and child to maximize the health of every child. She especially enjoys working with expectant and new parents of newborns to support their journey in a gentle, affirmative, and effective manner. Dr. Link works with families to help find solutions for children when they experience behavioral challenges. She is the medical director for the school-based health center in Winooski, in the Winooski, Vermont School District. Linda Lee, a licensed clinical social worker, works at the Community Health Center of Burlington as a pediatric social worker and child therapist, where she specializes in working with diverse populations, including bilingual and bicultural families. She was born and raised in Hong Kong and speaks fluent Cantonese, English, and Mandarin. A former interpreter and translator with the Refugee Resettlement Program in Vermont and Planned Parenthood, she now trains interpreters on mental health and offers provider training, such as this one, on how to work effectively with interpreters. She's a certified child parent psychotherapist, devotes her practice and volunteer time as well to racial justice issues. She serves as the board president of the National Association of Social Workers Vermont chapter. Welcome to you both, and we will begin with Dr. Link.
Hi, everybody. I will go ahead and get sharing screen. See if we can make it go. So hopefully everybody is seeing that now. Hopefully we've got sound, we've got video. My dog is outside, so hopefully she won't be barking through this either. So today I'd like to talk with you over the next 30 minutes and share some experiences that I've had while also using 3 explanatory models to improve patient-provider communication. So we'll go quickly through 3 models that are pretty detailed, and it'll be broad brushstrokes as we go through them. And I'll draw on some clinical experiences that I've had specifically in the last year to try to make some analogies and draw some real world examples in how communication that I've done probably could have been improved by leaning on different models at certain times. Again, I'm going to be briefly explaining this today, and the takeaway today is that these are 3 models that you can use. You don't have to employ every single model in every single patient encounter, or for that matter, every single component of each model in every single encounter. But as you explore and try out different aspects of each one, you may find that certain questions or approaches assist you in various clinical scenarios, and then you can draw on those again. The main thing I want you to leave with today is that these are tools and that this is a practice and that it takes time. I'm constantly learning and I'm always stumbling and trying to get back up. I included a few pictures. One of the main things that I do in my role as a pediatrician with the University of Vermont is work with newly resettled families from various parts of the country. And several of our families have come from some of these camps that are across the world. So in the very top is the Nyarugusu camp in Burundi. Many of the families that I see and hope to help are resettled from the Democratic Republic of Congo and have passed through this particular camp. Many children have been born there. In the center of the screen is the Dadaab camp in Kenya. There are actually several of these. There's a new book that's out called The Stars Are Scattered. It's a graphic novel, and it features 2 young men growing up in this camp. It's extraordinary. I highly recommend it. And that was for predominantly many of our families escaping violence in Somalia. Many of their children were born in the camp. Some of their older children may have been born in Somalia, but most of the kids have been born in Kenya in the camp. And then the other to the lower part of your screen is one of the Baldangi camps in Nepal, where many of our Bhutanese families have touched down upon for some time before resettlement. So I like these pictures, if only because it helps to lend a little bit of an idea of my mind of maybe where some lives touch down at some point. So even with those pictures in mind, and even no matter how much I try or how caring I may be, I get lost a lot. I think as providers, as social workers, as clinicians of all various types, we just stumble into waters and we have a hard time getting out sometimes. And when we find ourselves misunderstanding the patients and families we care for, we can misdiagnose clinical conditions, we can make medical mistakes, and we have a lot of medication misuse, underuse, or totally not being used at all. And the worst part about it is we can encounter lack of trust and community engagement. So the 3 models we're going to touch on today, and it's a lot of information, so we'll try to tackle it quickly. But there are 3 models. You may have heard of them in the past. You may have heard of different components of them. The first is Kleiman's explanatory model. So just to begin with, explanatory model is kind of a broad-based term. And it's there not necessarily for me to explain to you what's happening, but for me as a pediatrician to allow my patients and families to explain to me their understanding. And so often I feel like I walk into a room and I'm ready with the message that I want to deliver, but I need to be doing something completely different, which is receiving a message from the patients and families. And so employing various strategies in these models helps to allow us as healthcare providers to have it explained to us. So in Kleiman, Arthur Kleiman was an anthropologist and a psychiatrist, and he developed his explanatory model, which features 8 questions. And so it may seem like a lot, but I assure you they can be boiled down, and you don't have to draw on every single one every time you meet up with a patient. However, I love his description of his model, which in his original publication of it, he described as an exploration of the borderland between anthropology, medicine, and psychiatry. And I love the idea of the borderland, something in between that's trying to bridge 2 different groups. And again, using his explanatory model allows the patients to convey their understanding of what's going on with their health and their lives to us. The second model we'll explore today is the LEARN model, and LEARN is an acronym which I will lead you through. And this was developed in 1983 by Dr. Eloise Berlin as an elicitation method. So a way to draw out understanding from patients and then to engage in a bit of back and forth to try to hone that understanding and advance a treatment plan that's best for the patient and the family. It was developed as a framework for cross-cultural communication, and it does allow for the back and forth. And the third model, the ESFT, lots of very close sounding letters there in that acronym, has 4 components to it: explaining social barriers, fear and concerns, and therapeutic contracting. This was developed by Dr. Joseph Betancourt. He has his own Center for Inclusion and Diversity at Mass General and at Harvard. And this particular model is designed as a cross-cultural communication initially between nurses and patients, but it is very nicely condensed into 4 components. And I find that probably most of the work that I do actually kind of ends up in this particular model. So I'd like to just briefly walk you through Kleiman's 8 questions. And then I'll give you a little scenario, which will take through all of these 3 models and continue coming back to the same clinical scenario that I encountered just this past December, and use some of the aspects of these models to better understand what occurred during that. So questions 1 through 4, what do you call your problem? What name do you give it? Because your name might be vastly different than my name. What do you think has caused it? Why did it start? When did it start? How severe is it? Will it get better soon? Will it take longer? What do you fear most about your sickness or your problem? What are the chief problems this has caused for you or your family? What kind of treatment do you think you should receive? What does the sickness do to your body, and how does it work inside of you? Because a lot of the understandings of health and how things move through our body are really different among various cultures. Another Dr. boiled Kleiman's 8 questions down to 2 questions. Always appreciated when we work in the context of time. So Dr. Candula wrote in a post in the healthcare blog in 2013 during her work at Bellevue Hospital that she was able to distill his explanatory model to 2 questions. How is your health, and how do you know? And I've been trotting out some of these questions lately, specifically these 2, and I love the answers that I'm receiving from them. So this past year, in the midst of COVID, in my work and also my colleague, Libby McDonald, we were able to receive funding and support from the Vermont Department of Health to begin influenza vaccination in our school-based clinics in both Winooski, Vermont and Burlington, Vermont. This was a brand new program. Actually, vaccination had never been done in any of our schools since H1N1 in 2009. And that predated my arrival to Vermont. So what I found in developing this program to give influenza vaccine in the schools was a lot of questions. And so I was asked to participate in a short Zoom session, but actually wasn't all that short, as it turned out, to talk with concerned members of a community who were concerned about the vaccination being given to their children at school. So what to me seemed like an absolute no-brainer and a way to overcome multiple barriers to receiving flu vaccination in a normal year, this actually stoked a lot of fear and confusion among many families. So I also noticed that as I participated in the Zoom call and going through the preparation for this particular talk today, that I think that the discussion that I had on Zoom that night was actually a proxy for understanding COVID and for understanding COVID vaccine as we hopefully prepare to be able to vaccinate our children going forward in the coming months. I expect to be participating in many similar calls. So what I encountered during that particular Zoom call with respect to influenza vaccination was, what do you call this illness? What do you think causes it? What does the sickness do? What do you fear most about specifically the vaccine? What problems does influenza or influenza vaccine cause for your family? And what kind of treatment do you think you and your family should receive to prevent or treat influenza? What I uncovered and discovered was that there was a lot of confusion about what actually causes influenza. Is it cold? Is it the windows? Is it food? Going outside? I understood it to be simply caused by a virus, and that prevention is the strategy and vaccination is the way to do that. But that's not the underlying understanding in some communities that may not have had any exposure to viral theory before. So we did a lot of discussion on what influenza is, and the most pressing question that I found that I thought was very, very illuminative was, if you give my child influenza vaccine, that's great. Why do they keep getting sick at school? And I thought, well, you just hit that on the head right there. I get all the confusion right now in that little tiny question that they asked me. So using some of Kleinman's questions to advance this discussion probably would have served me. Moving on to the Learn as a communication tool. So the acronym LEARN, or listen, explain, acknowledge, recommend treatment, and negotiate agreement. So allowing these 5 little words that correspond to the letters to guide us in our communications with patients and families by listening with sympathy and empathy and trying to understand our patients and their families' perception of the problem, allows us first to understand where exactly we might be in trying to come to grips with either a diagnosis or what we even call something. And then the back and forth occurs in the E, to explain my perception of the problem, which I find is generally most helpful when I'm able to revoice back to the patient what they have just told me, hopefully as a signal that I understand what they said to me. And then I can say, so I understand this is how you described it. This is how I perceive this problem. And then we can start to have the back and forth. So then we acknowledge and discuss our differences and similarities. And when I can feel when this is going well, when I'm finding the differences and acknowledging that they're there, and then we find the similarities and the common ground, we're almost always able to move forward then as a team. And as a provider, you know when this is happening, you can feel this happening in a communication. And then recommending treatment in this scenario, and I'll go back through that, maybe this is a medication, maybe this is a surgical procedure, maybe it's talking about therapy, maybe it's talking about vaccination, but recommending the treatment as I perceive it in my area of expertise, and then negotiating the agreement. So again, the back and forth. So there's a nice back and forth of listening, understanding, giving my perspective, listening again, and a little bit of a back and forth as it moves through the learn. So employing the experience of my Zoom call back in December, answering questions, and then employing the LEARN acronym as a way to maybe better advance that conversation and come to a good understanding of what influenza vaccine is. What do you think causes influenza? Or in this case, a natural proxy for that is COVID. What do you think causes COVID? There are a myriad amount of answers to that question. Explaining this is where on my Zoom call, I got to dabble in viral theory. And I really did start at the beginning of viral theory and tried to break it down in a way that didn't sound overly stuffy, which took a little bit of trying. Acknowledging, but verbalizing a longstanding mistrust of institutions that exists among multiple cultures, and in particular the BIPOC community. And also agreeing, though, that we want to keep our kids from getting sick. So in this area, I'm able to draw on my experience as a parent and having my own kids have to be out of school because of illness. And in this year, being out of school because of suspected COVID. The recommendation of treatment is vaccination today, whether I'm in the office or recommending it at school. The recommendation I'm making is to proceed with vaccination. In this particular year, I was able to fortify that with hopefully saying, by giving influenza vaccine, if we can keep your child from getting influenza, that's probably 10 more days they'll have in school this year. And negotiating. If not vaccination, can we agree to talk again? Which usually sounds something like me saying, so I'm going to talk about this again. When can we talk about this again? And then agreeing to call also to follow up after vaccination. So in families that have been particularly fearful of vaccination and finally decide to go ahead and vaccinate, I often find a way to follow up with them just to see how they're feeling after that. So the ESFT model, again, developed by Dr. Joseph Betancourt, and he's got a wonderful website to support his Center for Inclusion and Diversity at Mass General Hospital. This has been in use since 1999, and it's there to facilitate culturally responsive care and cross-cultural communication. So lots of big, fancy words, which really to me just means a better way for me to understand and hear what's going on in my patients and in their families. There are 4 main components to this. And Katina sent me a beautiful graphic just yesterday, but I just wasn't quite able to tuck it into this for today. So it might be a touch small on your screen. But using the E as the explanatory model or the explain part. So while the whole thing is an explanatory model, the E really leans on the explanatory portion of this, where the patients and their families provide us with the information that they understand. And then addressing social barriers is the S part. And as a general pediatrician, this is where a lot of the work that I do lives. To take a look at the social barriers that might interfere with either seeking care or proceeding with treatment. Everything from insurance coverage to transportation to getting time off from work. And then beginning to discuss fears and concerns, which goes beyond me saying, you'll be okay, but really trying to understand and hear what patients and families are afraid of and concerned about. And then begin the back and forth of therapeutic contracting. So beginning to find the middle ground, what's possible to be done between my recommendations and a family's understanding and acceptance. So again, by using back to our Zoom call, by using the ESFT model, and here I'll draw mostly on the F and the T part, but backtracking a tiny bit to the S part, we use the funding and the ability to bring flu vaccination to the schools as a way to address the social barriers. So as a way to address the S part in a broad stroke. So by bringing flu vaccination to the schools, we hope to decrease absence from school simply for having to come to the doctors, needing to call a doctor's office to schedule an appointment for influenza vaccine. And for many of the families that I see in my office, but also in the Winooski School District, this is usually in a language other than the language that's spoken at home. And so communication may be difficult, if not sometimes impossible. And then allowing parents to have their children vaccinated at school eliminates the need for parents to get time off of work, and also eliminates the need to try to get transportation to a doctor's office simply for 1 vaccine a year. So we'd use the model essentially in that S part to begin to deploy our flu vaccination. And then focusing on the F, the fears and concerns, and the T, the therapeutic contracting, and touching back on the Zoom discussion that I had with the families that night, does this vaccine sound helpful to you? So some families perceive this vaccine as non-negotiable and possibly just part of something that they have to do. But I like families to understand this vaccine as something that's actually helpful and that they have a choice in. And so I hope and I want families to understand that the vaccine actually could be helpful to them, but they may not perceive it as that. But what have you heard about the vaccine? This is usually a box of just opening it up and seeing what's in there, because I can Google vaccine and come up and read for my entire lifetime. But trying to drill down a little bit into various families that exist within various communities, they may have specific concerns or may be receiving specific information from community leaders that might be out of sync with the information that I have. Have you or your family ever received vaccine before? How did it go? Did it go okay? Sometimes we don't hear about things. Are you worried about an adverse effect? Have I explained this to you in a way that makes sense? And so coming back around to the fears and concerns and then the therapeutic contracting, did I do my job? Did I explain this to you in a way that actually makes sense to you? What can you tell me about what we just talked about? Bring up my timer again. So what I like to think about is a particular topic is tossed around quite a bit, and that's the concept of cultural competence versus culturally effective care. And so these three explanatory models allow us to begin to engage in more culturally effective care. So I have heard about cultural competence ever since I began medical school in the year 2000. And it feels like it's an endpoint, like there's a test or a certification that you could get and then become culturally competent. But what I have found in practice in working with many different cultures from medical school through residency, working in another state, in another city, and now working in Burlington, Vermont, is what I find is that this is really an evolution of the way I work with patients. And there are plenty of times where I open my mouth and I may as well put my foot right into my mouth after it's opened, because whatever comes out after that is just ridiculous. And I try to stop, maybe beat myself up a little bit, and then go back and learn, what could I have done differently and better in that situation? Are there tools that I could lean on to guide me so I don't have to make it up? And the answer is yes. So by using these three models, Kleinman's explanatory model, the LEARN tool, and then also the ESFT model, and drawing on specific components and questions of them, we don't have to make it up in any given patient encounter. There are clear questions that are designed to elicit and advance any patient-provider communication. So culturally effective care is sort of a goal, right? It might not be an endpoint, but it's a goal that I might try to continue to strive for. And again, not to be seen as an endpoint, but more of the process of becoming aware of cultures that are different than my own, but even beyond the awareness, to allow these models to inform my practice and to strengthen the relationship between myself and the families that I serve. And in no other place, although these models are applicable to all patient interactions when it comes down to it, but I have found that there's no other place other than the work that I do with families that have been resettled through the refugee resettlement program or have arrived seeking asylum from countries. Does their experience in the healthcare system highlight gaps in services, health literacy, challenges in navigating the healthcare system that exist? So by doing this work and trying to do it better, hopefully then we can begin to close those gaps. So provide, oopsie daisy, There we go. I have just a couple of resources here. There are plenty more that you'll be receiving from other speakers today and also in the Q&A. But these are 2 places to go just for not being overwhelming. But I also would encourage you to take a look at Dr. Joseph Betancourt's Center for Inclusion and Diversity. The American Academy of Pediatrics offers a toolkit for working and providing more culturally effective care. And also in preparing for this, I found a wonderful set of resources at the Georgetown National Center for Cultural Competence. And again, it's a term that maybe needs some retooling, but the website itself actually was pretty helpful, easy to use, easy to navigate, and a lot of excellent tools that could be readily used immediately. That picture is actually Vermont. So that's from the top of Lone Hill at Shelburne Farms. So for those of you that are in Vermont or have visited, that's Shelburne Farms looking west toward the Adirondacks. And then just a series of resources, and I'm happy to further share those if needed. And we're just a couple minutes ahead of schedule. So I think we should probably prepare to stop sharing and turn this over to Linda Lee for her segment.
Okay. Heather, you hear me?
Thank you, Dr. Link, and welcome, Ms. Lee.
Katina, you hear me?
Yes, we hear you.
Hold on. Let me make sure you see the screen, okay?
Yes, we do, Linda.
Good, good, good. So, hello, everyone. My name is Linda Lee. Katina gave a really quick introduction of me, and I don't have a lot of time. I really concentrate my 4 hours training to half hour. So I'm going to dive into the materials, and thank you, Heather, for a really great presentation. But before I dive in, I have a couple, just 2 housekeeping things that I want to share with the group. One is I'm very fortunate and to be able to be both sides, to have experience on both sides of the equation, which is I was an interpreter. I am, I guess. I haven't been practicing interpreting, but I become interpreter since like 2005, and as a social work provider in a medical health setting. I sometimes use we interchangeably. So we could mean interpreter, we could mean social worker or provider. So just want to make sure that I clarify about that. And another housekeeping thing I want to say quickly is I have done so many trainings with myself and with others. And I know a lot of people here may have done trainings before. And we tend to, modify, twist and turn material that we have. So I want to make sure in this slide, there are a few elements that belongs to my partner and my good friend, Kathy Kelly, that we have done many trainings before. And we create a lot of slides together. So, so some of the elements I need to credit to her. So I'm going to start with, let me see if this works. Click, there you go. So what you will learn in this half-hour quick, condensed slide is the basic term and concept of interpretation, interpreters and clinicians' role, best practices, and interpreter resources. So why we should use professionally trained interpreters? It is human rights. It is the racial equality. I'm not going to discuss and dig into a lot of the laws, but I would. This is the link that you can, if you're interested, go in and read through it. Could be a good bedtime story because quite dry, but it is there. I want to clarify a little bit about trained and qualified. There is not really any official government document or language on that. I have found the interpreter term was interpreted on the ADA page detailedly, but it's not the language interpreter. It was sign language interpreter. And for the last version of the act, the ACA, the Affordable Care Act, has changed competent interpreter to qualified interpreter. So that means interpreters should be adhere to a ethical and have some kind of training and has to be holding HIPAA or confidentiality policies. I will explain it a little bit more. But if you want to know more about the differences or want to know what training I got, there's a lot of questions on that. What is qualified mean? What is trained mean? It's not like I'm going to give an example, a social worker that, there's a OPR, the officers regulation that have, if you are LICSW, you have to have 2 years of grad school, how many hours of clinical hours and pass an exam, very clearly detailed, but interpreter has no national standard. Going down. So the basic term, a lot of people have interchange about that, but really most of us are not translator. So translator really only means written. You translate on paper, you don't even talk. Interpreter is talking, verbal. So most of the interpreter are not translator. Translator is really about translating the correct document, law document, and most of the interpreter, even medical setting, court setting, they don't require you have a translator certification. So please, I remember one time NPR, they use translator interchangeably. And then in the afternoon, I heard them post an apologize or clarification correction that apologize and that they use it interchangeably. So just mindful and pay attention to it. Almost 99% of what medical settings are is interpreter. So this is what I learned or what a lot of the interpreter training use as the really basic, the first day that if you are being trained as interpreter that you learn this, the material I draw from is from Bridging the Gap program. So the basic function of interpretation is facilitate communication, represent information, accurately. And the mode of interpretations are mostly four. So consecutive is the most common one, that I speak one sentence, you speak one sentence. And we have a lot of experience on that in medical setting, mental health setting. Simultaneous is the easiest way to put it, is where you see most of the UN conferences or big government conferences that they do it the same time. They don't wait for you to pause, and the speaker doesn't have to pause. I tell you, it's really hard. If you have to go, like I feel like I cannot do it. Almost there is like you have to go to school to do it. And there's a lot of program in the US for interpreters training. I would talk about it later. Summarization, not recommended, but sometimes people do it. Just summarize a paragraph that people say, and we don't really recommend it to in any medical and mental health setting. Say translation, which means is you have a paper, you have a form, you read it out loud. A lot of the time I found it in medical setting and healthcare setting is a consent form, which is not the best model to hand it to the interpreter and say, hey, can you translate? They always say that. Oh, can you help translate to the patient? This is our HIPAA form. This is our consent form. No. You as provider, we as provider need to say it in front of the interpreter, and the interpreter will say what you say. It's not their job to do site translation. I would get that a little bit later. So let me go down. Okay, so position. Okay, that's the ideal. That's the ideal position. So usually the ideal position is provider, the interpreter in the middle, and provider and the client on the patient on the other two ends, or you're facing the two of them and then just interchangeably talk to them. Again, that's ideal. And if you, I have gone to interpret for 2 childbirth and the stem insert, like the heart, not the bypass, but the stem that you insert from the thigh. That was completely just totally not usable in this model. And but position is very important. And I would say that for provider, most of you are provider here, need to be mindful, because when you're in a surgical room and when you are in the birth room, and most of the interpreter is able to find the space, but please tell them where to go. We don't want to block anything that you need. So, so to continue, the roles of interpreter, when we as interpreter learn, 4 roles. It's contour. The basic one is conduit, interpreting everything, no addition, no subtraction. The other one is clarifier. So ensure that there's no misunderstanding. For example, we tend to, sometimes we forgot, we provider forgot to not use jargon, and as a mental health provider, like for example, PTSD, depression, sometimes there's no direct term for those, and I tend to oftentimes do more like a symptom-based and somatic-based explanation when I'm working with interpreter. But old habit is hard to change, and an experienced interpreter would be able to clarify. So I can, I think coming up, I would talk about how to switch role as an interpreter to making sure everyone is understanding everything. Cultural broker is very, very, very important. Interpreter is very tricky for interpreter sometimes, and provider, I think provider really, really should use interpreter as a cultural broker in a way that is a team-based in a way that doesn't affect or it is in front of the person, of the patient or the client. And I will talk more about it, about pre and post session later, to how to utilize interpreter as a cultural broker in a way that would enhance our knowledge and our understanding of our client's culture or patient's culture. Advocate is very, very rare in our role. In our role as interpreter. Sometimes I could give an example of a advocate is that a lot of the client, and especially sometimes I'm thinking about a Chinese old gentleman that I interpret for many, many years. He just smile and say everything yes, everything yes. And but he's not doing the thing. He learned how to be agreeable with providers, and it's not my role to tell everything to the or tell the provider things or tell the gentleman what to do. But what I would, after post session, I would ask, I think there is some cultural, misunderstanding there. And I would, ask you to dig more about the barrier. So very, very skillful and discreet because we are not paid our job to not do that. But this, I feel like it's very important. Sometimes we step out of a little bit of boundaries to make sure our patients get the care that they need. But again, it's like ethics. I can spend 3-4 days and we cannot agree on one thing. So, but I want to make sure that we all, sorry, multitasking. I mentioned it. Okay. So Interpreter 101 continues. So summarize a little bit. Interpreters are trained to interpret using the first person statement. So it's like I say, so and provider 2, please speak directly to your patient. Nah, can you ask her how she's doing? Can you ask her how she's feeling? No, you could speak directly to them. How are you doing? How are you feeling? And the interpreter would in turn interpret as first person. The patient said, I'm doing okay. I have pain today in my stomach. Same thing, the interpreter use I. And interpreters are trained to interpret everything was said between parties. Interpreters are trained with basic HIPAA regulation, and we instate confidentiality in the beginning of the session. Each time, interpreters are going to address HIPAA to both of the parties. We're trained to do that. I let Kristen and Bowen to talk more. And provider, please don't hesitate to address that too, because it's very small community here, very small. And it is very important that we really need to address confidentiality. You don't want to find out later that, oh, the interpreter is like an ex-husband of the cousin of the person, Interpreters are allowed to ask for clarification from all parties. So when word to word doesn't work, as I said before, that doesn't make sense, interpreter would do in both languages. Interpreter asks for clarification. What do you mean by PTSD? Ask the provider, will turn to the client and say, interpreter is asking a term PTSD, what that means. So it is a lot of hard work. It could be done. And I have experience on the other side as a provider that an interpreter did it beautifully. So that's other roles that when they are stepping outside of the conduit role, they will clarify about that. So everyone knows what is going on in the group. Interpreters are trained for basic medical and mental health. Now, I said it here is based on the Vermont. It's based on the Bridging the Gap model for the hours training that Vermont use. In other states, like I heard there's people from California, way different story, total different story. 4 years of degrees, and then you can keep moving up. And there's court certification. There's like all kinds of different levels, way more sophisticated. Interpreters are trained to switch role appropriately, as I said before, that when they step out of their role, they would ask for clarification. Let me check the time. Okay. Doing well, I'm doing good. Okay. So very quickly about different type of interpreters now. Phone and video, because of COVID, it has existed before, but now it's even used more widely. I'm going to quickly talk about what is the pros and cons about it. So phone and video, less management time. You don't need to pay for no show. You don't need to schedule way ahead of time. The big company out there have a lot of on-call interpreters. The quality may be higher. Maybe I have to say could be. I have experience before that, just people are washing dishes, people are children crying in the background, clearly they're at home. Yeah, so or you could be encounter someone in California that have gone through 4 years of schooling for interpretation. Flexibility, you can call anytime. Again, you don't have to schedule ahead of time. Difficult with children and community-based setting. Very difficult while you are trying to do an ADHD assessment with a child that is very active, and the interpreters on the phone cannot see anything, only hear banging, going, and that is not ideal. In person is preferred. Is preferred in mental health setting, in teamwork, especially team meeting. Pediatric social worker, so DCF meeting, a lot of them, and relationship building in person is really great for ideal for relationship building. As a team, treat interpreter as a team member. Sometimes it costs more, like you have to pay for no show and things, or sometimes confidentiality concern. It's not because of the interpreter, breaking rules. It's the client or person that don't feel comfortable, with such a small community. Actually, in Vermont, there's a lot of the confidentiality concern with in person. Or sometimes you get stuck. I have hung up so many times. I feel like fortunate that have been on an interpreter for so long. When I get like an interpreter that has, talking on the side, or making conversation with another person, with my patient, and or having a lot of noise in the background, you're not really concentrating, I just hang up. I just hang up and call back. But in-person interpreter, you kind of get stuck with what you have. Ad hoc is absolutely not recommended. Ad hoc means you use your front desk person, pull them in, that person speak Vietnamese, you put them in for like a visit. It's a bilingual staff that is not hired for the role. It could be for emergency, it could be good resources, it's convenience, but it's come up so many legal issues because interpreters should pay for a different pay grade. Like if I'm a licensed social worker, if I call upstairs for, a, doctor's visit or flu vaccine, and I am going to be, it's not ethical because it would add on my workload. I still have patients to see. And also the pay is different. So a lot of legal issue there. The best practice is to use hire bicultural and bilingual provider, not just speak a couple sentences of languages, but really bicultural and bilingual provider. So next slide. Change gear to the agency level of best practice. This is a really good resources for Katina had told me that there is some administrator here, not of the audience direct provider. So I specifically have share you guys with this link that has a very good guideline and standard to how to set up agency level best practice. Like basic is have a protocol, have appointed person or department who anyone would know. When I need interpreter, this is the person, this is the department I'm going to ask for or ask question about. Accessible materials for requesting interpreter and assessing interpreter, all those basic ones, best practice standard right here. I'm not going to dig too much, but this is the link that you can go in and share with your agency. Okay, provider levels. So I talk about being an interpreter. What do we supposed to know? What do we supposed to learn? Now, on the other side of the equation is provider level. So provide time and resources pre and post session. So that is what I mentioned about using interpreter as a cultural broker. Even though on the phone, allowed explanation of, so this is a developmental screening. This is a ADHD screening session that I'm doing with a mom and a 4-year-old, and it could be very, very, distracted, and we'll just give some background. Oftentimes we don't. We just get on the phone and just start talking, and especially, a lot of the time we do counseling. I like to oftentimes, even though there is a ongoing patient or client, if I need the interpreter, if I use a new interpreter, and if I use a phone interpreter, I often say that. So I'm doing, parenting, positive parenting training or session with this person, and I been meeting with her many times. So give a little bit background. It's really, I tell you, it's really helpful, really, really helpful. And the post session is where the provider can ask questions about maybe a new culture that they have, or maybe like some of the things that wasn't sure. I remember when Nepali and Bhutanese refugee first come here, I noticed a lot of head bubbling, and I wasn't sure if they're saying yes or no. So I asked a lot of questions. I use the interpreter as a cultural broker to ask a lot of questions. And there's a whole new world. There's a 3 days all-day training to just learn how to use an interpreter and build a team within trauma counseling session treatment. I'm not going to dig into it, but those are other resources that you can explore outside of here. Provider, please don't be afraid to discuss confidentiality often every single session. every single session. Treat interpreter as professional. As much as I, encounter some of the interpreter that not up to my standard, but there is a lot of interpreter that is very, very good. I have experienced this wonderful, wonderful Vietnamese interpreter helping this mother with her son that have autism, and he shared his own story with his nephew in a perfect way of stepping out of the world, stepping into the world, making sure I give permission for him to share the story and not just like side talk. It was beautiful. It was the best ever session I've ever had with an interpreter. And of course, I have to say USCI really have high quality interpreters. Don't use jargon. I talk about it, and especially in mental health term, and I mean, even though health term, use more somatic or picture. Try use the same interpreter to build a consistent provider interpreter team if possible. I don't think I need to say more. If you have one person every single time with the same person, with every single in a therapeutic relationship, it go way beyond. It go way beyond. Okay. Interpreters are not case workers. We are not case workers. We don't help them fill out forms. We don't help them fill prescription. I remember I have experience before that. Hand me a bottle or make sure this. Can you help the patient read the prescription bottle when he get it? No, I'm not a case worker. If you want me to do that, you need to call me with the client or patient. You give the instruction, and I will interpret. We are not transporter. Way early those days, we were asked to. Can you make sure you drive? Can you give transportation for the patient, for the client? I think right now is where now. We set a lot of boundaries on that. We're not medical provider. And as an example of reading the prescription bottle or instructions on how to take the medication, and those are the NA's job, or nurses. We are not scheduler. Please do not ask us to schedule other appointments. Oh, please, can you go help this person to schedule a WIC appointment? Or she need a cardiology department appointment next month. Can you make sure she schedule it? Oh, no. So community liaison. I'm not saying that interpreter cannot, liaison cannot be interpreter, but community liaison is different than interpreter. I feel like we are, as the community, are leaning towards the community liaison model that hire interpreters who can also do this work and pay them and give them the time, hire them as a staff to do that kind of job instead of using an interpreter that we pay by the hour and become the community liaison, if that makes sense. There's a whole model out there we can explore. I'm running out of time. Okay. Best practice, avoid. Please do not use family members, especially kids, as interpreter. A really quick story that I was called one day by a Chinese mother who said, the doctor told me I have parasites. What should I do? Like worm in the body, like parasite. I said, what? Why? What? Oh, my daughter, I went to the doctor with my daughter. My daughter helped, she was 8, I think she was 8. She helped interpret for me, and she said I have parasites. I said, what? Tell her to put her on the phone. So the 8-year-old tell me stomach bug. I said, oh, the doctor said mom has stomach bug. I said, oh, Jesus. It's flu, like, use jargon, and kids don't know stomach bug. Bug is worm, not the flu. So please don't use family member or kids. Use bilingual staff who hasn't been trained to interpret, same reason. And the reason I have said it before, that a lot of legal issues, HR, legal, labor issues, decide not to use interpreter due to logical issues, assuming their fluency, especially with detail or sensitive information. Please do not, assuming fluency. A lot of people, they can do day-to-day living with no problem, but about counseling and about like some really detailed, complex medical condition, please always offer interpreter. I have done exception though. I have, as a woman, mother, I speak another languages. English is not my first language. I have encountered a lot of the people refuse to use interpreter, but they're really proud of they can speak English. And there was this one very special case I'm going to share that is a mother who's so proud to speak English, and try really hard. And I am able to develop a very special relationship with her. And I said, you know what, I really want to help you to grow as a person who's learning English, but I also really need to understand. I need you and me to both understand. So could we make a deal? Could we, if I feel like you don't understand, I'm going to ask you to have an interpreter, and you be honest with me that you want it or not. Like I really want that you understand. And we did. We used a few interpreters, few times, and but that is a really exceptional case. And not to use interpreter. Katina is here. I'm going to go fast. Not to use interpreter because client refused. I have a slide to have some talking points. What happened if the client really refused? So I just really want to use my son. And it sometimes often happen that I think it happened before that the son is a professional interpreter. Like my son worked for USCLI, he's interpret. What do you do in that case? So so I have some talking point here, and one more slide. No, one more slide. Resources. ALV, USCLI, local, national resources, phone and video.
Is that it?
34 minutes.
Thank you. All right. Thank you so much. Thank you, Dr. Link. Thank you, Linda Lee, for those thought-provoking presentations. I think we can see and hear from both that applying explanatory models of illness and health is mutually beneficial for patients and providers. And so is, of course, the best practice of utilizing trained and qualified interpreters in medical and other settings. It's a high-level skill that we all need to appreciate. And again, there's mutual benefit. It's not just a benefit to the patient, but to all. So we are now going to take a brief stretch break, and we welcome your questions and reflections in the Q&A. Please put them in the Q&A, and I'm going to read them for our presenters to address in the next half of the session. We are going to be joined by 2 supreme panelists, and if there's time, we're going to have a wonderful interactive case study scenario. So please stay tuned for part 2. It's going to be fun and informative as well. Let's come back at 2:20, that's 6 minutes from now. 2:20 p.m. we'll resume. resume. Thank you so much. Hello, Dr. Lee, Linda Lee, and Dr. Link, would you please unmute your microphones for the,
Hi.
thank you for the Q&A. Thank you.
Sure. Do you want our videos on?
Either way. Yes,
Okay.
that's fine. So for the next 10 minutes, welcome back, everyone, from your short break. So for the next 10 minutes, our presenters will respond to your questions. So please put them in the Q&A for me to read for the presenters' responses, and we'll get to as many as possible before the discussion. I'm not seeing any right now in the Q&A. So if you need to send them another way, just please let us know in the chat, or if you're having trouble with the Q&A. So I would like to start out with a question to both of you, or I would like to start out and with Dr. Link. Thank you both, first of all, for your excellent, helpful, informative, positive presentations. So important for all of us. And Dr. Link, I loved the way that you incorporated different parts of the questions into the COVID-19 world. And I wanted to ask you if you could speak a little more about how you have negotiated in the past with patients about decisions for care, about a treatment plan or decisions. I love that you said that the quick example you gave was it didn't close the door to future dialogue. So I wondered if you could speak a little more about that part of the process when you're working with patients.
Sure. One thing I think I'm thinking of another clinical situation to kind of describe that. And I think there's one that I'm in right now with a young man who is clearly depressed, and he's an early teenager. And we've been seeing each other a lot. And there are multiple levels of professionals that work in my office that are involved with him and his family. And we are, I was just sitting in the office probably 2 weeks ago, feeling like I was in the midst of a misunderstanding soup, like just sitting in a pot of just misunderstanding at every level. And so, with trying to understand the diagnosis that as I understood it and what needed to happen, and then the diagnosis as the family understood it and needed to happen, and then decide what therapy to settle on. Because in depression, there are a lot of somatic complaints, headaches, body aches, belly pain, fatigue. And so this young man has persistently asked me for a medication to fix it. And he's been offered various SSRIs or selective serotonin reuptake inhibitors like Prozac or Zoloft. But that's not the problem as he perceives it, right? The problem as he perceives it are the somatic complaints. Mm-hmm. So in the midst of our discussion about this, I think I had to actually stop, and I think I was actually dressed in like full COVID gear in the midst of all this, which really like inhibits the conversation.
Yeah, that's good.
I sat down on my hands to make myself be still and listen and try to elicit from him what he felt he needed the most help with. And then to figure out from his mom what she felt he needed the most help with and what she needed the most help with to help him. Mm-hmm. And I will tell you, we have not fully arrived at the answer yet, but we are staying engaged in this conversation. And I've been actively trotting out various models and components of the models to try and further elicit what's going on so that I might at some point be able to land on the right type of help for this young man.
Very,
Lot
very
back and
quick.
forth.
Thank you. Very
Sure.
quick follow-up. Was he afraid of the medications and could not express that, or his mother or his family? Very quick follow-up.
He didn't seem to be afraid. He didn't believe that they worked.
I see. Okay, got it. Thank you.
You're welcome.
Thank you so much.
Mhm.
Questions from our participants, from our audience, please put them in the chat or the Q, well, start with the Q&A if you can. If not, please put them in the chat. And I don't see one right now, but I'm going to then ask Dr. I'm going to call you Dr. Lee. Just know that, Linda. I loved it that you spoke about treating the interpreter as a team member. And I'm wondering if you can expand on that a little bit. It's clear that interpreting is a high-level skill. I'm sure Dr. Link has also employed and utilized the services of interpreters in much of her care. But could you describe a little more about how providers can treat interpreters as a team member? What does that mean? What does that mean in a practical setting?
So before that, I want to totally answer another different questions that I want to
sure.
clarify that in the chat, there is Yulia, I believe, was talking about sign language. I want to clarify that
Yes.
my knowledge and my expertise are not in sign language. Sign language has a complete different set of regulations, skills, and my expertise is in language interpretation, not sign language. So whatever I said in my slides are about language interpretation. So I hope I make that clear. Sorry if I have not been very clear in the beginning. So to answer your question, treat as a member, maybe it would be better if I explain to share my personal experience and then also what the current trend is going on.
Okay. We have about 2 minutes. So
okay,
just to let you know.
So the trend is really hiring, utilizing community liaison is more like a person who's from the community that able to be the link of the two with the community and the agency and organization. And their job is also interpreter. And on the side, besides the interpreter, they have given permission and equipment to communicate and get feedback, or in their working hour to be the bridge of the community and the agency, kind of like a social worker on the ground that representing an agency. And of course, we cannot hire every single cultural and language, especially in Vermont. We have a lot of different diverse population. And one thing I really found that really connecting culture, I did a lot of interpretation work with connecting culture in the beginning, which is a UVM psychology department program, is they really treat me as a team member in a way that I'm frequently their interpreter. I know a lot of the providers. Each cases, they will call me to give me a pre-session, tell me this is what happened this year, referral, trauma case, and give me a background, and then ask me what do I, first of all, confidentiality. Do I know the family, right? If I have turned down many jobs because it's such a small community, and then also to ask me, any cultural question, any being a cultural broker, they pay for the time. They pay for the time that on that and that pre-session, and then every single session they try to make sure I'm present. So they make accommodation for me as your team. You're part of the team. We need you in there, and we will wiggle our schedule for you. And then also, of course, post-session. And this is the team, this is a team. I feel like that's my experience.
Excellent. Excellent. Thank you. Any observations on that question from you, Dr. Link? Any contributions you'd like to make? Thank you.
I think I probably have 30 seconds. I do view our interpreters as a team. Prior to COVID, I usually did a little happy dance when I knew I had an in-person interpreter working with me for the day. And over time, we've developed relationships with them. And there's just no way forward. I use interpreters for probably 70 to 80% of my patient encounters.
Okay, thank you. Thank you so much. So for the next part of our program, we are fortunate to be joined by two highly knowledgeable and experienced people working in this field, Bodwin Mulolo Mondaba and Kristen Rengo from the U.S. Committee for Refugees and Immigrants, Vermont. Mr. Mondaba is a highly sought after and talented interpreter and translator with over 25 years of experience. He is fluent in only 5 languages. That is a joke. Only 5 languages. French, Swahili, Lingala, and Kikongo, as well as English. For nearly 2 years, he has worked at USCRI, and he brings a unique and deep understanding to people from refugee backgrounds and others who have experienced severe trauma. He provides interpreter and translation services in medical and other settings. Mr. Mondaba was born and raised in the Democratic Republic of the Congo and holds an undergraduate degree in medicine and a master's degree in theology. Kristen Rengo is the coordinator of interpretation and translation services at USCRI VT, based in Colchester. And when she responds to our full panel, she will complete her introduction. So we'd like to start now with Mr. Mondaba. Please unmute your microphone, Bodwin. And he is going to offer comments on the previous 2 presentations, followed by Ms. Rengo's comments. And then we're going to hold a panel discussion to answer your questions and view your comments. Welcome, Bodwin.
Thank you very much for this opportunity. I really liked the intervention and the presentations of our 2 first presenters. I'm very happy to see that the way we have to consider the understanding of the client, the cultural understanding, and how the client is understanding his sickness is very, very important. I think for me, I want to add just a small thing about I start by the presenters. I will talk about what Lee said about the simultaneous interpreting to help the provider understand how to work in a very good way with the interpreters, even if sometimes the simultaneous interpreting is required, as in emergency room or in some psyche unit, but it will be the best thing to avoid all the misunderstanding and to make the interpretation as easy as possible. It will be better to do the best way is to repeat some questions most of the time, even if the client is not respecting the time or to give some time to the interpreter, but the provider, because he is aware about the difficulties that interpreters can face on simultaneous interpreting. So it will be very important that the provider, the doctor or the nurse may use a certain strategy, repeating the same question to help the interpreter handle the situation. Because when we just go like that without trying to repeat some questions, even if the interpreter can ask for can ask to the provider to repeat or to slow down, but the client, when the client is in a very good, a very bad condition, sometimes it is very, very hard to handle the situation. So understanding the belief of the client, according to what Dr. Link started saying by the Kleinman explanatory model, I can add something saying that it is very, very important to try to ask to the interpreter, because sometimes the client cannot accept to say something about the cultural boundaries. So if perhaps they can ask the interpreter some questions about the cultural, that can help the provider, the doctor or the nurse to understand something about the cultural. Because many clients, we realize that some clients, they came to the first appointment, and the next appointment they start avoiding contacting the provider. The interpreter didn't explain the cultural belief that the client could have. And after that, the client didn't explain anything, and the interpreter, because he can't say what he's thinking during a session, during a medical appointment. After that, when the client leaves without explaining the cultural belief, and the next time the provider can realize that the client is not coming. The interpreter can come, the interpreter comes, but the client doesn't show up. Sometimes you don't understand why they are not coming. It is perhaps because there is a cultural problem that you didn't understand about the case, and the client disappears. The interpreter will not explain to you because he's not supposed to explain during the session, and he just keep quiet. I can give some explanation. For example, you receive I can just give one example. You receive a client, he's having some seizures, some episode like that. You ask him to do, for example, the CT scan or MRI like that, or you prescribe some medications. But the belief for that client, for that psychic patient, the belief is totally different. They believe that the problem is not going to MRI or having CT scan. The CT scan and the MRI for them is like something they must not use when they are having that problem, and they know that the problem is from evil spirits like that. And according to what you have said, you can't give them some medication. That's why most of them, sometimes they throw away the medications. So the communication is very, very important. And sometimes, as I said, I repeat it, the person who can help to break, to remove all the boundaries, I think it's the interpreter. But he's not supposed to speak to give his own ideas during the session. So take in consideration all that things. I think this is my small contribution in the two presentations we had before. I encourage to help the provider, if the provider can help to have the conversation with the client, to let him speak, ask more question about some cultural barriers, and to do their best. If the nurse, the doctors can do their best to understand a little bit the belief of the client, it can be very important. And to ask some questions to interpreters, not to talk about the client, but the general understanding of the belief. And the belief, you can know some beliefs from a country, but in a country you can have different beliefs from a state to another state.
Yes.
So all those differences are very important to be known by the provider and to be taken in consideration. That's all. I think
That's wonderful.
other thing we can add it when we will have another opportunity to talk.
Baldwin, thank you so much. Those are very astute and important observations that are instructive, I think, for all of us. And maybe we can return to a couple of those points in the panel discussion.
Yeah.
Thank you very much.
You're
Thank
welcome.
you. Kristen Rengo, welcome. We would love for you to respond in any way you choose to the presentations about what struck you, other comments you might have.
Thank you. It's been a really great, fruitful opportunity for learning today. And I appreciate everyone's contribution so far. My name is Kristen Rengo. I coordinate the interpretation program at USCRI, formerly known as the Vermont Refugee Resettlement Program. And a couple of things that strike me today, I'm going to just go ahead and share my screen. A couple of things that have come up that I think are really important are the appreciation for the interpreter and valuing the interpreter as part of the clinical team. And this is just a really silly picture here of someone hanging on to two worlds and trying to bridge them, which is what has been mentioned before, and the importance of being able to work with someone who is a professionally trained interpreter and valuing them for that. It takes a really special person who has had the opportunity to learn so many languages, like as Linda mentioned, or as Baldwin mentioned, knowing only 5 languages and having the access to education to be able to actually interpret is a really important skill. Interpreters who work for our agency are trained on confidentiality, HIPAA, and also in harmony with the standards of practice set forth by the National Council on Interpreting in Healthcare, as well as the Code of Ethics from the International Medical Interpreters Association. As Linda mentioned earlier, there isn't like a Vermont state license like you would get if you wanted to operate a vehicle or cut hair, or in the state of Vermont for interpreting, but we have our own training, and this training and guidance is in harmony with the larger national organizations. And I've learned along the way. When I first started at USCRI a long time ago, when I was when I was much younger then and had less gray hair, my first role there was to help folks to find jobs way back when in 2008, when the economy was really challenging for finding jobs. So I would help newly arrived refugees find a job, and I relied so much on interpreters. And I learned the hard way the importance of interpreter boundaries and the importance of staying within the role. So the interpreter, as we mentioned earlier, in the healthcare setting and in the social services setting, is only there to interpret, 99% of the time to be the conduit of communication. And the as we also mentioned, as Baldwin mentioned earlier, how you can see sometimes that that perhaps the provider and the client are missing something. There are two ships passing in the night, and there's a disconnection being made. So that's why it's really important to see the different ways of coming at a situation that Dr. Link proposed earlier in our session today. And I'd like to share a little bit about one of the roles of for the interpreter, which is the cultural broker. And this is something that, that with transparency from both sides, both the client and the provider, and perhaps in a post session, after the session is over, perhaps the interpreter could provide some information of the cultural framework that influences thoughts, assumptions, values, etc. And it's really hard, as Baldwin pointed out, that even if you're from the same country as the patient, if you're from a different state or a different subculture from within that country, you may not personally be as familiar, but you may be able to observe that there is something that's not connecting. So that's why I really appreciate the cultural humility from Dr. Link to, be open to thinking about things in a way that really resonates for the patient or for the client. And there's a picture again of our iceberg that that Katina that you referenced in the beginning, about the things that we can see that are above the water and the values and assumptions that are deeply hidden below the water. So we really appreciate providers and interpreters who are looking with open eyes to help meet the needs of the patients and clients. So I'm going to stop sharing my screen.
Okay. Great.
Thank you. And then if anybody is out there working with clients who are English language learners, please feel free to reach out. Even if you're perhaps new to working with interpreters, you can always contact us, and we can help you to understand more about how to work with your client or patient. And then also another really important thing is feedback. We always really appreciate it if you're working with an interpreter and you have any feedback or questions or concerns following the session, please feel free to reach out. Thank you.
Thank you so much. Kristen and Bowden, thank you so very much. We had an inquiry just now about commenting out loud, which is, yes, we have time for 1 or 2 questions or more to the entire panel. So if Linda and Dr. Link would unmute themselves, and please raise your hand if you have a question and would like to speak your question. Please raise your hand and we will call on you. Be happy to do that before the next part of the program. What we may do, if I don't see any questions in the Q&A or the chat, is I think what we'll do right now is play a video case scenario, which comes from the Stanford University Medical School. Oh, we have a question. Sure, go ahead. Yes, please do. I didn't want to skip anyone that had a question. I'm sorry. Yes.
Hi, this is Lynette Reep. I don't know if you can hear me. I'm in
Yes,
my car.
we can, Lynette. Hi.
That's great. Thank you so much. I think it was me that you were inviting to unmute.
I was. Thank
Oh,
you.
very good. It's actually not a question, but just a piece of information to share. First of all, thank you so much for everybody's participation today. This is really wonderful for us. I'm the interpreter coordinator at UVM Medical Center, and it's so exciting to see a topic near and dear to our hearts here be the focus of the presentation today. So again, thank you. I'm driving to Albany and I've lost the signal at certain points, so I'm sorry I wasn't able to catch everything. But just quickly, I wanted to let folks know that the National Council on Interpreting in Healthcare was referenced earlier regarding the standards of practice for the field. We have just published a new paper on a closer look at advocacy and the role of the interpreter. And there will be a more formal rollout of that paper probably next week. So I'll share that with Katina so that she can get it to anybody who's interested.
Absolutely. Thank you so much.
You're
Please,
welcome.
please do. Is that the end of your comment, Lynette? I don't want to.
It is.
All
Yes,
right.
just wanted to share that.
So thank you so much.
Feel free to remute me.
Okay.
Thank you.
For all of you, to let you know, we, after every session, we compile a list of very important resources that are recommended by our presenters, in this case, presenters and panelists, and also our experts in the field. Those guidelines, the ethics guidelines, and others, and what Lynette just referenced, will be sent to all of you at the end of the program, probably sometime next week. So I was going to mention that at the end, but since Lynette brought it up, I thought this was the perfect time. So you will receive a list of phenomenal resources that are useful to you. All right, so we are ready to play a video case scenario from, as I was mentioning, from Stanford University Medical School. And in this scenario, a patient, a family member of the patient is the interpreter. We're ready. Thank you, Nicole.
Next is the first scenario where you will view an encounter where the physician allows a family member to interpret for the patient.
Mrs. Chen, I'm Dr. Franklin. If it's okay with you, we use your son as the interpreter. It just gets too complicated to connect to our people and we'd have to wait, so if you don't mind.
妈，我帮你翻译。
好，你的英文讲得这么好，我的儿子他有电脑的学位 ，sample， 他从小就把我翻译的。
We can use me.
Great. As you know, we've been treating you for quite some time with chemotherapy, and you've done really well. Your cancer is under control, but as I've told you before, we can't cure it. And I am a little bit concerned that your spleen is enlarged.
医生说，他们有药可以医你的癌症。他也说你的胃比较大。
这是好消息，真是好消息！谢谢，谢谢医生，谢谢医生，我很高兴。
Okay. I'd like to do some tests to see what's going on and give you some new medication. Now, this new medication might give you stomach upset, so if it does, please let us know and we'll give you something for it. Now, I know you're in pain, so it's really important that we control the pain so you can have a good quality of life. So please let us know if your pain is not controlled.
Okay.
All right, we'll fax the prescription to the pharmacy.
那他在讲什么？
他说我们要去药房去拿你的药。
Great. What went wrong?
Okay. So would all our presenters and panelists unmute themselves, please? So the question becomes, what went wrong? Please, if you would like to comment on what went wrong or what went right in this scenario, please raise your hand and we would love to call on you. And then we will ask one of the presenters to comment as well. So then let me ask a question to Any of you that would like to respond, presenters or participants? Did the interpreter, did the family member who served as the interpreter interpret everything? Baldwin? Anything, you don't have to answer that question, whatever you.
I have many things to say about that.
Okay.
I will say just what I can say, and I think other people can add what they have. I'm very concerned about this interpreter because, and I have some concerns about the doctor too, because there are some mistakes in the with the interpreter, and the provider to the doctor didn't help the interpreter, because even if you don't understand a language, you can understand, or you can know if the language, if the message is understood by the client or not. So the first big mistake was when the provider said about the cancer and the spleen that was enlarged. The interpreter said that the cancer will be killed, but the provider said that they are not able to help to get to remove all the problem with the cancer. He can't be healed about the cancer, but they will do their best to treat and to give some painkillers like that. But the interpreter said the cancer will be healed. And after that, the client was thanking. The client started thanking the provider, and the provider could understand that the client didn't understand the first message they gave her, but the provider accepted to continue without asking some question to the interpreter, and it was a miscommunication about that. And
Thank you, Baldwin. I don't want to cut you off, but I'd
Yeah.
like a couple other people to comment. If we had another hour, we could keep this conversation going.
Yeah.
Thank you. That's so valuable. Maybe too, I don't know, but maybe the family member didn't know the Mandarin words for spleen. Maybe, maybe that was part of the problem, that he as a family member did not know the medical term, which a trained interpreter would have known. Linda, or any of the other panelists, presenters, would you like to comment too on this scenario?
Sure. It seems everything is wrong in that one thing they did it right was the position. That's the only thing that it was correct in the video. And also the subtitles actually correct. That the mother is really saying what the subtitles say, not the son said. And as Bao, I agree with him that there's many things that it was just not right there. And will be interesting to hear the participant speak.
You mean in our audience here?
Our audience, yeah, sorry.
Yes,
Our audience.
I'm looking to see if anyone would like to raise their hand. Please do. This is the time to raise your hands. We're monitoring the Q&A and the chat. So, all right, we have a question from Alyssa. Alyssa, if it's all right, I'm going to go ahead and read your question, if that's all right. It says, it seemed to me that the doctor had a feeling that there was missed communication. If she followed up, I can see that it would be helpful. It was painful to watch that missed. Yes, that's all right. So Dr. Link, would you like to comment on that?
Sure. I mean, training videos always are sort of the worst of the worst, right? Or the best of the best. And really, the reality is somewhere in between. I think that, the provider in that scenario missed a huge opportunity to even begin to engage with her patient. And you say the entire E portion of Dr. Betancourt's explanatory model, just trying to elicit any understanding of what's happening. And that was just really, cast aside in the beginning. I understand sort of the nature of the beast of her clinical encounter, where essentially she had to relay lab results and deliver a treatment plan probably in 15 minutes. But again, there's about 25 steps that occur before that, whether you're using an explanatory model or not, and you're just being a nice person. But using the explanatory model in every single one of the three that we talked about today, recommendation of treatment and negotiation of the therapeutic plan is at the bottom for a reason.
Thank you so much. Any other quick comments from the other panelists?
Another question I had was, or another thing was, just wondering if that were a real life scenario, what would have been going through the thought, what would the thought be from the provider? Like, it's too hard to get an interpreter and you're here, you're here now. And so I think it really takes a lot on the side of the provider's office, or, Lynette joined us from UVM Medical Center. There's a lot of work leading up to it in order to get the interpreter and the patient and the provider in the right spot at the right time, in person or over Zoom. So I just would like to honor how much work that is to get that in place so that you can have the professionally trained interpreter there, or over Zoom or over the phone, to do that the right way, as opposed to relying on the family member.
Thank you so much. Thank you so much. So it shocked me when I saw this, and I know it's a training video, but going back to what all of you have said, it shocked me that the provider did not ask one question. She talked. She did not even elicit any concerns, right? Fears, what Dr. Link was mentioning, explanations. She didn't ask one question of the patient. It was pretty startling, actually. And also, maybe the family member chose to omit messages that were uncomfortable, right? That he did not want to convey to his mother. That part of that was an uncomfortable message, wasn't all good news. And it was omitted. And we don't know how he felt about that. And again, a professional interpreter would not do that. So all these things occur, if you all agree, I think you would agree, pretty frequently when family members interpret, right? This is not an unusual video. This is not an unusual scenario. This is pretty typical. So we're going, yes, please.
I was just going to say one more thing, that at the beginning of the session, usually the interpreter has the opportunity to do the interpreter's pre-session, and they remind everybody in the room that everything will be confidential and everything will be interpreted. So if you have a situation where the doctor's coming in and relaying bad news and the family members are there, this is one of the scenarios that comes up in our training, where the adult child who speaks English really well jumps in and says, no, don't share that information with my parents, because I'm concerned if they hear that bad news, then, that will be bad for them. That could be a cultural piece. So when the interpreter is professional and they have the chance at the beginning of the session to remind everybody everything will be interpreted and everything will be confidential, then it sets the tone for everything will be interpreted and everything will be accurate and confidential.
Thank you. Absolutely.
So it's really hard when everybody has only 15 minutes to jump in there and get in there. And of course, with interpretation, everything takes longer, but that's a really good investment of time.
Excellent. Thank you. We're ready to finish rolling this video to conclude this part of the program. Nicole, at any time you're ready. Thank you.
Encounter takes a little bit longer. In the long run, it saves time and money. When you use an untrained interpreter, be it a relative or another staff person, or decide not to use an interpreter at all, it can lead to unnecessary diagnostic testing, uncompliance with the treatment plan, decreased patient autonomy, and even medical errors for which the medical institution is liable. Using interpreters increases patient compliance and leads to fewer return visits and fewer tests done. If your patient speaks some English, they may be shy about telling you that they don't fully understand what you have said, which can also lead to negative results.
If you rely on your own limited second language skills, you portray a less professional image to your patient. By using a professional interpreter, you ensure professional communication and provide excellent customer service. Limited English proficient, or LEP patients, may limit what they say because they're afraid you may not understand, or because they don't want to say certain things in front of family members acting as interpreters. This decreases patient autonomy, hinders the patient-provider relationship, and may have clinical consequences.
Thank you so much. Thank you all. So for our last few minutes, we're going to have some conclusions and some highlights of next learnings, how we can go on and continue this journey in cultural efficiency and cross-cultural communication that is equitable and fair. So in just a moment, we will have some additional slides. And I wanted just to speak briefly with you about the application to practice. We've identified some best practices thanks to all of our presenters, but just very quickly, there are some other best practices or tips that you can use in your setting. Try to identify influential cultural differences in yourself and your patients. Again, that's a learning process for both of you that builds mutually beneficial encounters. Build awareness of the differences in communication style that may influence care, verbal and nonverbal. Consider the roles of silence in each patient encounter. Those silences could represent discomfort with a topic or uncertainty about a question being asked. Silence speaks quite a bit. Paying attention also to nonverbal cues can help determine whether a differential power relationship is hindering communication. Linda already mentioned booking longer and repeat visits with the same interpreter is beneficial because it forges trust and understanding around health issues. And devise a tailored treatment plan that involves not only the patient's immediate family, but the extended family as well, or other community members as appropriate. Finally, recognizing that diversity exists, and Bodwin mentioned this very clearly, within ethnic and cultural groups as much as between groups, and avoid generalizing or stereotyping cross-cultural encounters. Communication style may be a family's cultural norm, and stay attuned to tone, body language, and other nonverbal cues. All right, so in conclusion, we're getting towards the end. All cultures do matter. And by making all cultures matter, our patients' cultures should be seen and can be seen as strengths. And what I mean by that is when healthcare is not rooted in the patient's life and experiences and strengths, patient care suffers. And all cultures matter because it serves as the foundation for high quality, empowering, and patient care. Biases and stereotypes can take hold, and deficit perspectives can become normalized throughout our healthcare institutions, structuring systems that blame patients for failure, rather than looking at the patient through a cultural lens. Today, we have learned that cross-cultural patient care is not a soft skill, but a key clinical competency for all healthcare providers. Cultural competency training suggests that culture can be reduced to a few technical skills for which clinicians can be trained to develop expertise, and then therefore they are declared culturally competent. But research shows that systematic attention to and understanding cultural factors improves clinical services and health outcomes. So by incorporating these culturally informed best practices and strategies into clinical settings, such as the ones we've heard about today, healthcare providers and organizations can lead the way toward more just medicine for all people. Finally, we know that changes by practitioners alone in the clinical setting cannot combat disparate treatment and the harm that it causes minority patients. So the culmination of this 5-part series will be our final session on building and cultivating effective healthcare organizations from top to bottom. So please join us on Wednesday, May 26th at 1:30 p.m. for this unique event. Registration is going to be open this weekend, May 1st, and you will be notified of that. So in conclusion, I would like to leave you with a snippet of wisdom that I became aware of about 5 years ago from Nelson Mandela on the centrality of language in our lives as professionals, but also as individuals in society. If you talk to a man or a woman in a language he understands, that goes to his head. If you talk to him in his language, that goes to his heart. In conclusion, we want to thank you, all of our panelists and our presenters, for an excellent and exciting session. I would like to remind you, please, to complete your evaluations that will be available to you after this session. And again, remind you that we will be sending you resources and next learning questions to share with your colleagues in your work environments. We encourage you to work and play with these resources as it's appropriate for your growing and learning in a collaborative fashion. So thank you all, and hope to see you on May 26th. Best